California Healthcare Foundation, and we're delighted to have you join us today. This is an informational webinar about the Opioid Safety Coalitions Network and our request for letters of interest for organizations interested in leading the learning network and program management. We will be going through the series of slides for your information, and then we will open it up for questions at the end of the presentation. Because we have many people on the phone, for your comfort, we're going to be muting everybody during the presentation, and then we'll unmute people individually during the question and answer. This session will be recorded and accessible after the webinar. We will post the slides and the recording within a week at our website on the Opioid Safety Coalitions Network section of our website. If you have a question at any time during the webinar, just write the question in the Q&A box, and I will respond at the end of the presentation. Or you can raise your hand at the end, and we will unmute you so you can ask that question. And I'm always available for questions after the webinar is over. Of course, if you have any logistical questions or challenges with the presentation, please chat to the host, and Glenda can assist you. So during this session, I'll be going through a little bit of background for those of you who don't know us well. We'll be talking briefly about the California Healthcare Foundation's opioid initiative, an overview of the coalition's network. We're going to talk about an assessment that we commissioned and some of the findings from that assessment, and then what we're hoping the program manager would take on, and a bit about the letter of interest process, and then of course questions at the end. Many of you have seen the map at the right, and this was the map that inspired the foundation to take on working across the state on the opioid epidemic. Because when you look at national statistics, California doesn't look that bad. We look about average in terms of opioid prescribing and opioid deaths. But when you look at the variation across our state, there are some counties that are severely affected by the opioid epidemic, as West Virginia and Kentucky. And even though some of our southern counties, rates do not look that bad, the actual numbers of people affected because of large populations is quite large. So when we, in 2015, when we started this work, we really asked ourselves, what would it take to get to zero overdose deaths in California? Many of these faces are people who died from the opioid epidemic, show every single one of these is preventable. And so when we looked at what resources we had as a foundation and what resources we had within our state, we aligned our activities with the guidance from then Secretary Burwell, the federal guidance that informed the work from the Health and Human Services, CDC, Public Health, and others. And that is first focusing on overprescribing. Since we've quadrupled our prescribing rates in the last 15 years, it's reasonable to get at least down to half of where we are now. And the foundation's focus has been on decreasing the number of new starts, those people going on to chronic daily use, and identifying people on high-risk regimens and then tapering safely while managing their pain. And the reason I focus on that is there's been a lot of emphasis on safer prescribing as defined by pain agreements and tox screens and risk assessments. And while those may be helpful, we don't yet have evidence that they lower overdose rates. But we do know that if someone never starts down the path of daily opioid use, they're not going to overdose from that medication. And we also know that while some people may do perfectly well on low-dose opioids, those who are on high dose are at high risk and need to be worked with individually to make sure they're safely brought down to a safer, manageable regimen. The second major priority is building new access points for medication-assisted treatment for opioid addiction. We've got plenty of evidence that this lowers death rates and improves the retention and treatment, and so we're working across the state to build new capacity in multiple places, primary care, especially addiction programs through the drug Medi-Cal waiver, emergency departments, and telehealth, jails, and others. And finally, until we're able to decrease the supply of opioids in our communities and decrease the demand from better addiction treatment, we have to stop the overdose deaths, and that's through making sure naloxone is available in community settings so that clinicians, when they prescribe opioids, also prescribe naloxone, that it's available in needle exchanges, that pharmacies are able to furnish it without a prescription, and where it makes sense, having first responders have naloxone in place. So the approach that we've taken across the state is all related to partnership, because we're a small foundation, and the joke is always the Medi-Cal program spends more by 10 a.m. every morning than we spend in a year. So we really try and leverage our resources. And so with this work, we've had close partnerships with state agencies, public health, health services, justice. We have supported Smart Care California, which is an alliance of purchasers, health plans, and providers. We've got a big project with community health centers across the state supporting medical assisted treatment in primary care. We've had several publications where we found gaps in the literature, and we welcome you to go to our website and review them. And then the topic of today, and where we think a really important lever is with local coalitions. And that's because culture is local. It's very hard to change prescribing culture, to build up addiction treatment, to deploy naloxone unless there are local leaders in communities making those changes. And so if you go on to the California Opioid Surveillance Dashboard now, you can get a sense of how we're doing. Now, of course, it's hard to know the work that all of us have done in the last 2 years because the data is still not up to date, but they're actively working on getting it up to date. But for now, when we look to 2015, across the state, we're slowly dropping opioid prescribing rates. We're slowly increasing buprenorphine rates. Nowhere near what we need to meet the demand, but we're making progress. But the opioid overdose deaths has still been fairly stable, and it's we don't yet know whether we're dropping that significantly or whether we're holding course. Because of course, when you look at our success with dropping prescription opioid deaths, we're seeing that unfortunately compensated by rise in heroin overdose deaths from many sources: the increasing supply, lowered costs, increased potency, contamination with fentanyl and carfentanil. So lots of work to be done in making sure we have enough treatment access, because as we've seen in the drug wars, a supply side solution of just trying to block new heroin imports hasn't been successful. But in France and Baltimore and other places, we've seen dramatic drops in death when more addiction treatment is available. So again, the reason we've invested so heavily on coalitions to do this work is because if you're going to change an individual clinician's prescribing habits, that doesn't happen from Sacramento. It has to happen through peers, through medical societies, through conversations locally. If we're going to move past this not in my backyard attitude to build new addiction treatment resources, we have to engage local consumers and families and advocates and boards of supervisors. So the reason local coalitions have been so powerful is that it has both got this combination of getting everybody at the table who's impacted by this epidemic, but also with this urgency of making plans to make concrete changes within the next year. So these are not coalitions that are trying to aim at 10-year policy changes that are focused mostly on process. These have been very action-oriented groups who've gotten together with providers and pharmacies and public health and education consumers to sit around, look at the data in their own neighborhoods and make a plan for how to change prescribing habits, increase addiction treatment, and increase naloxone supply. So the structure of the program that we started in November 2015 was that we offered a small group of coalitions, 16 of them across 23 counties, a package of intensive support, and that was some core funding that was modest but helped with some administrative costs for coalitions to be able to staff with project managers and to host events and keep the trains moving. There was a suite of technical assistance from both physician leaders who had led their own coalitions, a quality improvement coach, trainings that were both virtual and in person. We had the assistance of co-funders, so that although we had initially only intended to work with 10 coalitions, we were able to work with more because of with the assistance of these co-funders. And then when we recognized that more and more coalitions were launching over time, we opened up all of our offerings, both the virtual webinars and the big in-person convenings, to any coalition working in California. And we now know of 36 counties of California's 58 counties that have active coalitions working in their communities. So this kind of momentum is so exciting, and the ability to link all of these counties to learn from each other is why we want to continue this network. We've heard so many stories of one county trying to figure out how to engage their police department and another county giving them advice about it, or a county saying no pharmacist will stock naloxone, and another county having a pharmacist who is a leader in this call that pharmacist and explain how easy it is to do. So again, no one needs to solve this problem alone. Many of the rural counties have problems in common and solutions in common, and so what we've really tried to do is make sure that everyone is linked to each other and can learn from each other. So these little red dots are the counties that we worked with intensively and the technical assistance that was more personalized, and the blue counties are those who have active coalitions that have, in one way or another, attended a webinar, attended a convening, or have reached out to us to talk about their work. Just briefly, although it's too early to measure the success of coalitions in terms of death rates, which is our ultimate goal, we've seen so much progress. Several coalitions started off with getting emergency departments to set up guidelines. So even though emergency departments are not the main source of prescriptions, they're fairly small volume, mostly primary care doctors like myself, at the same time, it often can be the first place where people are exposed to opioids. So having more and more emergency departments agree to practice in a consistent way is so powerful. And I remember a story from Los Angeles where they said, I think it was 74 out of 75 emergency departments had adopted these prescribing guidelines, were giving them out to patients, everyone was talking a similar language, and then the 75th emergency department was a holdout until so many patients were saying, well, if I can't get it here, I'll just go to that emergency department because I know that they'll give me what I need, and that emergency department gave in eventually. The reason I tell that story is just the power of everyone practicing together, because when you know that you can be treated one way at one place and another way at another place, what it does is it just pushes patients with untreated addiction to settings that are not going to be able to recognize and treat their addiction, and it's not safe. So we've seen really great stories. Another example is Sonoma County, where they got all of their primary care providers together with their emergency department and public health, and they all agreed to similar practice standards. And so again, both in the interest of patient safety and consistent practice, that was very powerful. As I mentioned, especially with the heroin increases, CHCF is doing a big focus on building addiction treatment access, and so we've seen incredible success, along with admittedly big challenges, but lots of great stories showing progress in building out medication-assisted treatment. And although there's many different options to treat addiction, CHCF has been focused on medications because it has the best evidence in terms of dropping death rates and improving retention and treatment, dropping HIV and Hep C rates when people convert to heroin. So again, primary care, emergency department, health plans getting involved, hub and spoke programs, and this is a big new initiative from the Department of Healthcare Services. If you're not aware of this, I really encourage you to find out more, because there's a grant opportunity for any program that wants to participate in building new medication-assisted treatment access, where the hubs are specialty treatment programs and the spokes can be primary care sites, mental health sites, and others. So, and then the third area, we've just seen some amazing stories about deploying naloxone into the community. One county had a librarian administer naloxone and save a life in a library. We've seen more doctors and nurse practitioners and PAs get on board with, when they prescribe daily opioids, prescribing naloxone as well. And one of the powerful things about this intervention is that it's been shown to drop ED rates in half, even if the naloxone is never used, just because the conversation that happens when someone is given a prescription for naloxone in case they stop breathing, it really wakes people up to the need to be so careful with these medications. So we commissioned the Public Health Institute to do some data analysis and interviews and site visits to understand, in this last roughly 18 months, how can we measure the impact of coalitions? And we have many, many stories and many process measures to show how they've made progress in those communities, but we really wanted some quantitative data. And it was encouraging to see, and anybody who is interested, we can send you the full report. Just email us and we're happy to send you that report. We'll be publishing a version of it eventually, but we want to make sure you have it in case you're interested. We did find that when looking at opioid prescribing, both in terms of the total opioid dose per resident in that county, the rates by county, and the total on high dose opioids, defined by greater than 90 morphine milligram equivalents. Those counties that we worked with that had active coalitions that got the CHCF intensive support along with our co-funders dropped these rates greater than other counties. And these other counties could have coalitions, may not have coalitions, but were not in that cohort of 16 coalitions that we worked with intensively. So that was encouraging to us that we knew that the first thing that would change would be prescribing. It would take longer to build up the addiction treatment and longer to drop death rates, but at least we're trending in the right direction. We also asked what are the things that were useful for you? So we asked coalition leaders to rank all of the different offerings that we did in our 18-month program. And so we saw a variety of responses, and some of the responses that showed that were not used by all coalitions, we still think are valuable. So you'll see, for example, communications assistance in our request for this new program manager. But what we found is it's really not a one-size-fits-all, that some coalitions are so sophisticated they don't need any communications help, and others are just getting started and they can't even think about communication support until they build up the basics. So again, what we learned from this is that having a menu of options and then having that customized to the needs of the coalition is probably the way going forward, since the coalitions have many things in common but are also quite distinct in terms of the population they're working with, the sophistication of their infrastructure, their internal resources. And the other thing that was really interesting from this assessment and what we learned from looking at other states that are doing similar work is that our focus initially on healthcare, which is specifically let's work on prescribing, let's build up addiction treatment resources, let's deploy Naloxone. We made a lot of progress with that, but the things that coalitions were struggling with, like getting attendance at meetings, running meetings that people stayed engaged in, accountability, these are things that are predictably, once you get past those early wins, are really needed for coalitions to keep going and to go strong. And the Technical Assistance Center in Pennsylvania has just done a brilliant job in supporting coalitions in that state. And what they found is that they really needed to focus on how to run a healthy coalition in the same way you think about how to run a healthy organization, that a high-performing organization is going to have a clear vision and focus. They're going to have effective leadership and management. They're going to be able to set goals and keep people engaged and enthusiastic about those goals. They have sufficient knowledge and technical expertise to do the work, and that they've been able to engage broad stakeholders. And this is, I don't want to underestimate how hard this is. You know, doctors like myself don't often speak the same language as law enforcement, and it can be an initial challenge when we're sitting around the table trying to solve the same problem with very different tool sets and very different attitudes about those tools. And so we're thinking that this next phase of network support should really focus on this, this idea of how to build a healthy and sustainable coalition. So when you look at this slide, which is a logic model for what are the inputs that will lead to the result of what we're looking for is decreased overdose and deaths. These, of course, will be available on slides and is available in the report if you want to look at it more detailed. The blue sections were the support services that we offered in the last 18 months, and the red areas were what we think are part of the next stage that were both recommended in the Public Health Institute's assessment of the coalitions, that we've seen be successful in other states like Pennsylvania, and that we also heard from coalition leaders that would be helpful. So, for example, we didn't focus a lot on how to advocate for policy change, both local and statewide. This was articulated as something that could be very powerful in the next phase. We also didn't spend much time thinking about how to support leaders in the hard work of leading across sectors, because there can be challenging turf battles and, again, culture differences. So this is another piece that I think is important. We did focus on getting everybody going with a dashboard and the use of data, but I think there's a long way we could go. So helping coalition leaders measure their impact in real time and set short-term goals, so that everyone's focused on overdose deaths. This can take years to get there. So how do you know what you're doing is working in the short term? And finally, we really heard that although some things need to be customized, people are so busy that would be very useful if there was more materials and supports that was templated and standardized and pushed down for use. You know, for example, why should everybody have to invent a way to help pharmacists furnish naloxone? Well, DHCS and the Pharmacy Board came up with a toolkit that this is how you furnish naloxone. And these are the types of things that we heard would be more helpful, is to have more templated resource guides and more standardization. So what we're asking of the network manager is to have 3 tiers of support. And this is negotiable. We would really like to choose a partner who will help us figure out what's best for the coalition, what will help them go the furthest. These are our initial thoughts, but these may be modified over time. But our thoughts are that there's a core level of support we want available to the whole state, because there's so much work to be done and there's so much that can be scaled. So, you know, possibility of having a website that is constantly scanning other states and across the U.S. and bringing in resources that could be useful, or educational resources, offering webinars based on feedback from coalition leaders for what's needed, bringing together convenings either regionally or statewide or both, and then pulling together real-time information, ideas of what other coalitions are doing to be shared in some monthly digest form. And we've found that people have enjoyed this when we've pulled together stories and pushed them out once a month with helpful tips. Then the next tier of support, we don't have enough resources to offer this to every coalition in the state, but we've heard that having a monthly touch point with a coach was very helpful. Sometimes it was as simple as someone saying, okay, last month you said you were going to do these 3 things. I'm emailing you now because we're going to talk in a week about how these 3 things are going. And then when you talk in the week, you problem solve. Sometimes having that external coach helps you keep going when there's so many burning fires and competing priorities that have your attention. The other thing we've heard is just having one person who knows everything that's going on in the state is helpful, because when one coalition says, I don't know how to solve this particular problem, the coach can say, well, the coalition next door solved that, let's get you both on the phone. And that's the kind of support we think would be available for a smaller group. And then finally, what we heard from the assessment, and which we were interested in, is this idea of could we choose a small group of high-performing coalitions that have already made a lot of progress and give them a little bit more resource in terms of core support and some more intensive help, and get them to go even further and have them be exemplars for the state. And so that's the current thought we have of these 3 tiers of support. So we, because we don't have enough resources, for example, to give every coalition some core funding for project management. We know some coalitions have gotten some core funding from CDPH, from partnership, but that's something that we're thinking about as well. Finally, the other network manager responsibilities, we want to have some expertise in policy advocacy and prevention. Although CHCF's goal is to change the healthcare system, and we want to maintain that focus, we've heard from coalitions that they also want to have some skills that are a little broader to engage other stakeholders, for example, in stigma reduction. We want to make sure that coalition leader, that network manager, is curating and sharing curriculum content, again, focused on organizational health that we mentioned before, having some expertise or bringing in expertise in improvement science, which is really how do you make change happen and how do you make it stick. We want to make sure that those coalitions have help with measurement and data monitoring, and then again maintaining that focus that we've had all along of overdose prevention strategies, of safer prescribing, MAT, and naloxone. All of this information is in the LOI letter, and I'm happy to take questions at the end. So again, we do have the benefit of UC Davis, who is doing a big evaluation funded by the CDC on the impact of coalitions, and that's more, that's going to be trying to correlate the activities coalitions do with the impact by county. And so we don't have to do a big evaluation of our own work, but what we're looking for is an organization who can help with more real-time monitoring, again, to help a coalition figure out what I'm doing, how do I know it's working now. An example is medication-assisted treatment. How do I have a dashboard that's measuring my impact and getting more addiction treatment access? How do I know what the demand is in my county and if the supply is sufficient to meet the demand? This kind of real-time understanding of what's working. We also want to make sure we stay coordinated with everything else going on in the state, and that's been a real powerful role of the foundation, is essentially being the glue to pull together things happening with state agencies, with purchasers and providers and plans, and all of the different activity across the state will be more powerful together. So the network manager will be a key person to attend our periodic statewide work group meetings that are led by Dr. Karen Smith, the head of public health, and she brings together state agencies and leaders across the state to coordinate all of our activities. So that's going to be an important role for this network manager. And finally, we don't know what the future looks like. Should there be an organization like Overdose Free Pennsylvania, which is run out of the University of Pittsburgh, that has independent funding and is expected to be a long-term technical assistance center, or should this just be another 2-year effort that we phase out over time? I don't think CHCF will have the resources to continue to support this work indefinitely, so we would like our partner to work with us to think about whether this network should stay longer than 2 more years in place and what kind of funding could help do that. In terms of organizations, we don't have any preset thoughts about who the right organization is. We just have a group of characteristics, knowledge, skill, and experience that we're looking for. And I would say above and beyond this list, we're looking for a thought partner, a partner who's not just taking a list of tasks and executing it, but really helping us think about what's going to be the most impactful on overdose deaths across the state and helping us move towards that goal. So in order to get there, it's a lot of work managing a network well and being both individually responsive to leaders' needs, as well as having a strategy and kind of curriculum arc that's internally coherent. So skills with program management and curriculum development are really helpful. Again, there's a whole science of how to make change happen and make it stick, and we're looking for those who've got some type of experience in improvement science. We found that teaching and coaching are really helpful skills, so this organization should either have that or contract for that. We've heard that the most helpful type of coaching doesn't necessarily have to be a subject matter expert. For example, it doesn't have to be a physician leader of another coalition, but somebody who is really good at accountability, at pushing, knowing that balance of pushing people along to make change, but also being respectful that everybody's busy, everybody's overwhelmed, and trying to find that right balance between nudging and facilitating and helping problem solve. This organization doesn't necessarily have to be an expert in the opioid epidemic, but certainly able to pull in those resources. The budget is between $500,000 and $1 million. That's a pretty wide range, since I'm not yet sure what it will take, and I would like the network manager to be able to help think through about what's the best use of funding, because of course Foundation has limited resources, and money we spend here is money that we're not spending building up addiction treatment or defending the goals of defending the gains of the ACA. So we want to have both sufficient to make an impact, but we still want to be frugal. This budget does not include funding for coalitions, so I'm going to be going to our board, and assuming this goes through and is approved, we have another $500,000 that will be available for direct coalition support. So this is just money that would be used to fund the network manager. We're proposing a little over a 2-year time frame that would start in September. And we want to respect your time, since one of the things I get frustrated by is foundations who ask people to do massive RFPs with no chance of them getting funded. I really want to be respectful of your time. So that's why we came up with this thought of doing a 2-page letter of interest so that we can find out from you what are the core competencies and what's your vision of what you can do, and then sort through those and choose a few organizations that we really think have the infrastructure needed to do this work, and then we'll ask those organizations to do a longer RFP to compete for this contract. So our thought is that if you can get us your 2-page RFP letter by June 15th at 5 p.m., If it's helpful for you to add resumes so we understand who is on the team and which consultants you bring in, we won't count those to the page limit. And then again, we'll tell you by June 21st, and then we'll set a date in mid-August when the full proposal is due, and we'll also announce that finalist by late August so we can start the work in September. Although we as an organization have committed to goals across the state, a drop in opioid deaths by 10%, we think that we can do better within these coalitions that we're working intensively with. So we've set ourselves goals of dropping prescribing rates by 50%, thinking if we've quadrupled our prescribing last 15 years, dropping by 50% still preserves opioids for where they're urgently needed in palliative care and hospice and trauma and severe acute pain. We don't want to live in a world without opioids. They're very helpful and useful, but we want to make sure they're used appropriately. We want to see a drop in opioid-related ED visits and hospitalizations, since these really represent failures in the system. If you're going in with a non-fatal overdose or an injury from a car accident from opioid overuse, we'd like to see these drop, and of course a drop in opioid overdose deaths. This is really difficult, but Baltimore dropped their overdose deaths by 39%, largely through a massive increase in addiction treatment. France dropped their death rate by 80% by making buprenorphine widely and freely available. So we think this is achievable, but we think that the piece that's going to really be needed is not just all the prevention work and prescribing work, but is bumping up our addiction treatment access. And buprenorphine prescribing rates is a good proxy for that, since that data is available on the statewide dashboard by county. It comes from Cures, so you can look on the statewide dashboard and find out what your buprenorphine prescribing rate is and see that change over time. And we also want to make sure that Naloxone is out. We don't have a way to measure this statewide other than what's in Medi-Cal, so we're using Medi-Cal as a proxy, but certainly want to see each county find ways to measure how they're getting Naloxone out into the community. So this is just a quote from a coalition leader in San Luis Obispo, and I wanted to end the presentation here, is that before everyone pulled together in a coalition, it felt like we were operating in a vacuum, but together we have a multiplied effect. And that's the thing that I've seen so powerful is what happens and how fast change happens if we're pulling together across the state. So that is the end of my presentation. I'm going to, at this point, if you have any questions, ask them. I'm just going to read the questions aloud, and then if you want to raise your hand and let us know if you have a question, Glenda, if you can help me by unmuting those who raise your hand. I'm just going to take a look at the questions and read out any that might be interesting to the group. There was a thank you for hosting the webinar. Let's see what else we have. Oh, that's all I've got. I just had one note that said thank you for hosting the webinar, and you are welcome. But I don't see any other questions. So feel free to chat or ask questions if you have them, or raise your hand. And Glenda, I can't see it. Do you see anybody who's raised their hand?
Sarah, I've unmuted you.
Hi, I don't actually have a question just yet. I figure if as we're kind of looking at our letter of interest, we'll go ahead and send you an email with any questions. Is that okay?
Of course. Yeah, I'm totally happy to receive questions. My email is there, and don't be shy.
Okay, great. Thank you so much.
It looks like Timmy has a question. Timmy, I've unmuted you.
Hi, Kelly. Are you going to be sending out the deck?
Absolutely. Well, you know what we could do is send the deck out by email as well, just because it takes us a while to get the recording on. So, Glenda, if you could help me by collecting the names of anyone who registered and send them a PDF of the deck today. That way it's available sooner than the recording is.
I will do that.
Liz, I've unmuted you.
Oh, thanks. Is there another Liz? Is it me?
Oh, Liz Galicia, I noticed you had a question.
Yeah, you had mentioned the 3 priority goals at the start, say for prescribing, MAT, and Naloxone. Would you say that that continues to be, that kind of outlines them as sounds like it could be an order of priority, and I know there's been gains in safer prescribing. Can you talk about what you're seeing in terms of priority goals and what you're looking for out of the network moving forward?
Thank you. Yeah, I continue to see those as the ones that have the best evidence. The safer prescribing, we've been a little bit more nuanced about, since so many people interpret safer prescribing in different ways, including just doing lots of drug screening and pain agreements, but not really changing the volume of prescribing. So where we've seen the most evidence is that it is in the new starts. If we can decrease the number of people who are starting on chronic opioids, and the way to do that is through changing how we treat acute pain. There's a great study that came out recently that showed a linear relationship between the number of days of opioid exposure and the chance of being on opioids long-term. Something like 6% if you only take it for a day, 13% if you take it for 7 days, and then it goes up to 67% of those taking it for 90 days are still on 2 years later. So we know there's a lot of work to be done around changing how we treat acute pain and not being so cavalier about giving a month's supply with minor injuries. And then in the safer prescribing bucket, that second category of identifying people at high risk, and those are high dose or using benzos and opioids at the same time. And the reason I specify those two is that we have great evidence. If you take people at high dose and slowly taper them down over sometimes months or a year, that their death rate drops and their function improves. If you take people at high dose and you suddenly cut them off, as we're seeing happen in very reactive places, then those people are incredibly high risk of turning to street drugs and overdosing. So again, we're trying to focus our message on safer prescribing really specifically in the high risk, and then trying to mitigate the harm of the work on safer prescribing to make sure it's still available in palliative care and hospice, and that we're not going after 80-year-olds on 2 Tylenol of codeine a day. There's some way that if we go too far in the other direction, we're going to do harm. So again, we want over the next 2 years to continue to focus on safer prescribing, MAT and Naloxone, but we also recognize that coalitions have other local priorities, and that's where we'd like the network manager to customize and be flexible to local needs, and be able, if a local coalition says, I really want to think about how to go to our board of supervisors and create some local ordinances that help us do this differently, then that's a resource we'd want the network manager to be able to bring in and help with. So in summary, keeping those 3 priorities, but having flexibility to be responsive to local needs and add others as well. It looks like Jacob Coverstone had a question. I've just unmuted you. Jacob? Monique Sula, you had a question? I just unmuted you. Okay, how about Christine Fenlon? You had a question?
Yeah, hi Kelly. Just want to double check. You mentioned that we could get a copy of the full coalition report that you guys paid to have done, and that we just need to request it. Is that anywhere on your website currently, or not yet published?
You know, we haven't published it partly because there's a lot of nuance about data. So we wanted to work with actually the public health department and think about what's the best way to share coalition success, because the data that I shared is looking at all of the county prescribing rates, and then looking at on average how do those county prescribing rates compare to others, and there's some complications with that, and if I'm not ready to go out nationally and say, you know, this is the best way to look at the data. I think the data is portrayed in this way is really helpful in terms of quality improvement and understanding what's working and not working to inform our next actions. I'm not sure that way of sharing the data is the only way to share that data, and we just needed a little bit more time to think about what's the story we want to tell publicly and what's the best way to tell it. And the report is quite long and detailed, and I think of great interest for the people on the phone, may not be as much interest broadly. So what we could do is we can just we can share that report with anybody who's on the webinar, and you're welcome to share it with your organization. Just don't publish it on a website until we've been able to to work on it a little bit more. It was really just a time issue that we weren't able to do a public edit yet. It's a great report, and I really encourage you to read it. The Public Health Institute did a spectacular job at gathering information and pulling it together and telling a story in a really compelling way.
Excellent. Thank you. Yeah, looking forward to reading it.
Amy Max, you had a question? I just unmuted you.
So just one question.
Amy, we don't hear you.
Oh, can you hear me now?
Elise, it looks like you had a question and I've unmuted you again. Elise Pomerantz. All right. Christine Cristobal, I just unmuted you.
Hi, Kelly. My question is, I'm wondering how you envision clinical leadership playing a role. In other words, do you expect that the network manager is going to bring that expertise, or do you have designated clinical leadership in mind regardless of the chosen network manager?
That's a really good question, and I think the way I would answer that is that if the network manager has a clinical leader who's deeply knowledgeable about that work, that's a plus, but it's not a requirement. I think if the network manager doesn't have that person on staff or contracted, but that has all of the other pieces in play, then I think we would work together to figure out how to bring in that component. What I mean is that there's a role that I've played in being really front and center with the coalition's work, and I'd like to pull back a little bit and have some of the role that I've played done by others, so I can continue to focus on other work. And I also think there's a way that for physician leaders or clinical leaders in coalitions, it's very helpful to have other coaching from other clinical leaders on specific topics. So not every coalition needs to be assigned a physician mentor, for example. But if every coalition had a single point of contact and that coalition said, you know, I would really love to have Dr. Ronit Lev come and give a lecture at our kickoff meeting because she's so powerful on the issue of emergency department guidelines or using cures data to tell stories. You know, that network manager would pull in that expertise, but that, you know, obviously people like Dr. Lev have full-time jobs. So again, I think that it's not an expectation that every coalition network manager would come in with a FTE of a clinician leader. If you have it, that's great. If not, then we would work together to figure out how to bring in that expertise.
Great, thank you.
Monique Shula, I'm unmuting you if you have a question. And Sarah Wendell.
No, I don't have a question anymore. Thank you so much.
Okay, great. And let's see if there's anyone else whose hand is raised. And Jacob Coverstone, one more time I'm unmuting you. Questions. Okay, great. And let me just see if there's any other. Okay, so Jacob, you don't have your mic on, but if you want to ask the question by the question box, let's see. And if you give me, I'm going to just take a look at the question box and see if there's anything else that I didn't answer. Okay, can you speak a little more about the approach for aligning efforts with the California Department of Public Health on coalition support? Great question. That right now, as some of you may know, Dr. Smith convenes a meeting every other month with every state agency that is involved in the opioid epidemic in some way: Justice, Health Services, Managed Care, Medical Board, Dental Board, et cetera, and that also has invited other leaders, including county leaders across the state. And so one simple answer is the network manager would attend those meetings and would give regular updates about what's going on with the coalition. Another way that may work is the CDPH has its own funding of 12 different coalitions, and is also funding some technical assistance support. For example, academic detailing of individual prescribers to change prescribing patterns, big communications campaign across the state. So it would be very important that the coalition network manager knows of that work, coordinates with that work, so it doesn't feel like a county would go to CDPH for one thing and the coalition manager for another, and each in the right hand wouldn't know what the left hand is doing. The Department of Health Care Services is funding several coalitions with a big focus on prevention and youth. So the network manager needs to know about what's going on in that area as well. So again, it's not like the network manager would be working directly on those projects, but should coordinate and know what's going on with those projects so that they can get mutual benefit, and so CDPH can know what's going on with these coalitions and take advantage of that and vice versa. And for the goals, what's the baseline measurement? We're using 2013 just because how do I answer this? So we've been using 2013 for our board, mainly because our data only goes to 2015, and we wanted to start looking at changes from that date. So I would say that we'll continue to use 2013. Again, this is not a hard line number because we're certainly not doing any pay for performance or dinging people if they don't hit the 20%. But since some of the work that we actively started in 2015, we've just been using 2013 as a baseline. Okay, the next one is, can you talk more about the cultural competency aspect of the work? Are there particular ethnic, racial populations that are being prioritized with a focus on addressing disparities? So I would say that this is, we remain concerned, as many do, that because there's been such a white face of this epidemic, and that historically people of color have been criminalized for addiction, that everything we do has a disparities lens on it. And we try and think about how to make sure that all of the energy that's been mobilized across the divide, possibly because this is a way of getting into the homes of people who, and legislators who have been, it's not been so up close and personal, that we make sure that we are thinking about disparities. And so some counties, that's less relevant since they're fairly homogenous, and other counties like Los Angeles, where Caucasians are a minority, then we would want to make sure that the coalition work, when it's focusing on addiction treatment, for example, is looking broadly at how addiction is hitting different populations differently, and making sure that any new addiction treatment offerings are tailored to those populations. And a good example is Los Angeles is starting to work on addiction treatment, medication-assisted treatment in jail population, recognizing that's one area that's been discriminated against, where other healthcare services are available, but FDA-approved medications for addiction treatment have not been. So I don't know if that's much more of a general answer, but I would think that this would be something we need to learn about as we go with each coalition in each county. Where are the disparities, and how should that inform the work? So how much travel is required by this grant? We don't have any travel requirements. I have heard from coalition leaders that the in-person meetings have been invaluable, and that the way that we've done the in-person meetings, which has been a combination of keynotes and panels, that although that's been great, people are really craving for more time face-to-face with other coalition leaders to learn from each other. So when we choose a network manager, we'd want to work with that organization to think about how do you get the most advantage of face-to-face networking while recognizing how hard that is, especially for rural communities that it's hard to travel, and urban communities where traffic is a limitation. So somehow we want to find the balance of making information and network opportunities available to all while recognizing in-person always adds a level of value that virtual cannot. So there's no specific travel requirements. The Sacramento meetings that are run by public health can be done virtually. A lot of this work can be done virtually, but at least a few times a year we would expect that some regional work groups would make sense, and we'd have to work with you on the frequency of that. I think initially when I put the budget together, I was thinking of an annual statewide or Northern and Southern California event and then some smaller regional events in between. There are opportunities to collaborate with others. For example, San Diego has hosted an every other year big statewide summit that's going to be in November of this year. So there may be opportunities to piggyback on other statewide meetings and take advantage of that structure to get people together. And certainly we would encourage that. Okay, I'm still going through some of these questions to see if there are other ones I've missed. Okay, who can we follow up with and when is the best time to contact to discuss more about the type of organization and short-term and long-term goals? I would say contact me by email and give me some specific questions to see if I can answer them by email, and if not, we'll set up a time for a conversation. So any questions that were not available, not answered during this webinar, we certainly encourage you to email. The person who asked that question about short and long-term goals, if you can either raise your hand or put in the chat box something more specific, I'm happy to answer it in this webinar. Otherwise, we can talk offline. When will the presentations be posted online? We always do it within a week. We'll certainly try and do that sooner. As I mentioned, anybody who is on this call will receive a PDF slide deck by tomorrow. But in terms of the online, I'll have to defer to our team internally, hopefully within a few days, but definitely by next week. I got a question, is MAT now higher priority than safer prescribing? I would say for the CHCF, our overall opioid initiative work, MAT is our major focus over the next year. That really has to do with there's so many other forces driving down prescribing rates, and while we're not dropping that focus, we're continuing to work with health plans and provider groups and others on safer prescribing, and we know that coalitions will need to look at the data in their own county and see, are they making progress or are they stalled, and we'd want them to use that data to figure out how much of a priority to continue to push on safer prescribing. So in summary, I would say safer prescribing is still a priority because then until we drop the total volume of opioids landing in our communities, in our medicine cabinets, and exposing us unnecessarily, the work will continue to develop new populations of people with addiction. So both are important. I would say you'll hear from CHCF a much bigger focus on MAT because it's been a harder lift. There's still a big gap between those who need treatment and aren't getting it, and there's so much other work going on around safer prescribing, so it doesn't need to be the CHCF's primary focus. Will the responses to questions asked via email after this webinar be made available to all webinar attendees? That's a really good point. We want this to be a fair process. So I'm just trying to figure out how to do that logistically. Why don't we do this? Any questions that I answer by email that are not very specifically relevant to the individual, I'm happy to send out to the group. That will mean you get emails that you you may get some emails filling up your box, but I'm thinking that may be certainly a more fair than giving more information to one group than another. So yes, if I answer anything that's not very mundane or specific to an individual, I'm happy to share it with people on this webinar.
Kelly?
Yes.
This is Glenda. I think what we can do is collect questions and do one blast to people maybe on June 9th, Friday, so that they have time to incorporate that into their responses, which are due the next week.
That sounds like a great idea. So why don't, if anyone has any particular questions, if you can get them to me within the next 24 hours, and that way I can answer them all as a group. Glenda, thank you. Very smart suggestion. I'm right now looking at the questions to see. Glenda, do you see anyone whose hand is raised that we have not answered yet?
It looks like Timmy has another question.
Okay, Timmy, we're going to unmute you. Timmy, any other questions?
No questions. Helpful. Thank you.
Great. Okay.
And then there's one more, Amy, back.
I'm unmuting Amy. Okay. Oh, okay. Amy's self-muted, so I can't unmute her. But Amy, let us know by the question box if you have an unanswered question. Okay, it looks to me that we've answered all the questions. I'll give you another few seconds to ask the question if you have it, or to raise your hand if you have a question. Okay, it looks like we've gotten through all of them. So again, the letters of interest are due on June 15th. If you have questions, please email me in the next 24 hours so we can email the group and make sure everybody gets the benefit of that response. I hope this webinar was useful to you, and we'll sign off. Have a great day.